Thank you, Marcy. Now I will turn it over to Dr. Donaldson of our Health Plan Administration Division to moderate our next discussion, along with all of our health discussions for today. So welcome, Dr. Donaldson, and would you please introduce your panel? Thank you.
Thank you, Mr. Jones. This morning, we're going to talk about delivering health care in rural California, both challenges and opportunities. For this presentation, the agenda will cover rural markets and network challenges, the Department of Managed Healthcare, who actually regulates our health maintenance organizations and where they can deliver services. We will hear about opportunities from the population health and public health perspective, and then we'll hear the final speaker on telehealth and telemedicine and some of the changes that are very exciting that will help us reach our rural areas with better care. I'm Kathy Donaldson, Chief of the Health Plan Administration Division, and I am the moderator for this panel. If you look at California, we are large and we're diverse in terms of where our rural areas are located. We have mountainous regions to the north and to the east with forested areas. Oftentimes they're accessible by narrow roads, and we have rural communities that are small and sometimes isolated. If you look at the heat map on the right, it shows where we have HMO coverage. Those are the white areas in the county names. The PPO coverage, our own self-funded preferred provider organizations, are designed to reach all counties within California. You can see different shades of green through the valley and on the coast and down into the southern part of the state. That's where all of our HMO coverage areas are located. And we'll talk later about our HMOs this afternoon. These areas in the north and the east, where our PPOs are, and to the desert, are home to state workers who serve Caltrans, CAL FIRE, corrections. They also serve our local governments, and they serve our first responders. But also residing in these areas are our retirees and our California veterans. In these counties, especially to the north and to the east, we see that we have higher costs associated with delivering care. For example, we've already shown that we have higher cost of opioid prescriptions in the north. And we also have difficulties in delivering quality care for maternity. And then finally, access to care is a challenge. So let's look at some of those challenges further. Geographic access is just demonstrated. Those counties are rural and they're hard to get to, and some of the communities are isolated, which makes accessing care difficult. Providers are limited in specific areas, and in some cases, our members have to seek care in Medford, Oregon, or Reno, Nevada. There are provider shortages. That is, some providers prefer not to live in certain areas, and new doctors may not be attracted to some areas. Also, for some of our providers, they may have closed panels or they're planning to retire. So provider shortages are particularly important in care delivery in these areas. And finally, specialist care and ER care is difficult in terms of access. And it's also an important component to building any HMOs in any future areas. However, we believe that there are plenty of opportunities for us to improve our care. Harnessing community resources, and you're going to hear from our panel about how that might be done in terms of working with the communities that they serve and in sharing resources. Taking care to the patient. Instead of getting the patient from where they are to the care, what about new ways to take care to the patient? That could be done through mobile clinics, possibly biometric screening by the mail, which we've already shown as part of our value-based insurance design, mobile units for ancillary care. So, and also the potential for home care. New technologies are making it possible that we might be able to deliver care more to the home through some of the technological advances that are coming onto the market. Also, our value-based insurance design, which this board approved, went into effect in January, and that design is meant for a value-based insurance that reaches all 58 counties, that finds a provider that will take care of our patients. Our patients are incented through a lower deductible, and we are working on 100% attribution of those members in PERS Select to be attributed to a primary care doctor that will direct more of their care. And finally, alternative access policies are possible through the Department of Managed Healthcare, and Shelley Riard, who's from the DMHC, will be speaking to that. And then telehealth and telemedicine and new emerging technologies made possible by changes in legal structures will finalize the presentations from this panel. I'd like to introduce our distinguished panel. We have Aldo De La Torre, who's the president and CEO of the Community Healthcare Plan, which is a Southern California plan that stretches across the Fresno area from Coalinga to the Eastern Forest. We have Shelley Riard, who's the director of Managed Healthcare, who will talk about DMHC regulations and where we might maximize opportunities. We are fortunate to have Barsam Khosravi, who is the interim plan president for Anthem Blue Cross. And while Blue Cross is our third-party administrator for our PPO plans, he will be speaking about population health, public health, and leveraging resources in some of these areas. And finally, we're very fortunate to have Mei Kwong, who's the executive director for the Center for Connectedness and Health Policy in California. And her presentation is going to let us know what can we do today where we might not have been able to accomplish some things in prior years. Now I'm going to turn it over to Mr. Aldo De La Torre, who is going to start our presentations. Thank you.
Good morning, everyone. So I'll try to keep the comments brief because I do want to make sure I leave enough time for questions. That's what the panel is for. Just a disclaimer that my opinions and what I'm going to present today should be viewed through the lens of a jaded network contracting guy who has spent many times in these rural markets establishing networks for Fortune 50 health plan. I also I'm still faced with the certain challenges because for those of you who know the Central Valley, there are distinct rural parts of that area, particularly where growers will employ individuals. There are very few access points for them, so we struggle with that. And if you followed the recent press, we've had a number of hospital closures in that area, which stresses the system even more. I'm going to speak to this presentation, but it's really just to keep me on track. This is the service area that we serve. As you can see, we don't go all the way to the coast, but we do cover most of the central area there, and we do have those challenges in those West Fresno markets that you could expect, even to the point now where we have growers and employers wanting to build their own clinics to service their employees. They have reached a point now where the system is stressed quite a bit. And as the president of a health plan who wants to ensure timely and appropriate access, that creates challenges for us as well on the private insurance market. But you can't really look at California. No, we typically look at California and you look at the studies and it's a north-south thing. And I think that most people think that Northern California stops in Sacramento, San Francisco. This map I thought was pretty interesting because it does fairly represent kind of how networks work in California. Kathy didn't mention this, but beyond being a jaded network guy, the pink area at the top, I actually grew up and was raised in that area. It's now it wants to be the state of Jefferson. I'm not sure how that's going for them, but there's enough folks up there where I sometimes lose track of where I'm at. But anyhow, I grew up in Weed, California, so I'm not only in the business, but I actually receive most of my care from rural areas. And so I have some of that experience to draw from. I still have family there that relies on those areas for their care, so part of my comments might be skewed to that experience as well. as Kathy mentioned, you can't really talk about rural healthcare with the challenges without first mentioning the physician access piece. It is acute throughout California, but it is even more acute in the rural markets. Kathy has laid out a couple of reasons why, just trying to get folks to want to pursue that lifestyle, move to those areas, and practice in a rural setting creates some challenges. There's isolation that exists. There's spouses that maybe that's not for them. And what we find these days that we talk about recruitment of physicians. It's not as easy. It's because there's a small pool and there's a great demand. What's happened, though, is we've had to use a lot of our dollars from recruitment to retention. So we try to add physicians, but a lot of the proceeds that we have available for that have been redirected to retain the physicians that you recruited previously that might be wanting to leave town, or you lose those physicians and you have to start all over again, and that's even more expensive to do so. So one of the challenges is that this pool of dollars that health plans or hospital systems have to recruit physicians is being redirected to retention, so not really expanding the pool. We're just trying to keep what we got. I'm not a researcher, but I found a couple of facts here to share with you that kind of compare metro markets to non-metro markets. And so in the metro markets, we have about 28.9 physicians per 10,000 residents. And that's in the non-metro markets, you're down to about 15.8. So you have fewer physicians obviously in those markets, but that's on a per 10,000 member population, so it's normalized. What's even more troubling, though, is that you look to the future and the average age of physicians in those markets. So if you have a physician in the rural market, ages 55 to 64, they represent about 35% of that workforce. In the metro markets, it's 20.9. So there's a younger group of physicians in those metro markets. So we have a rural market that has trouble attracting physicians, and the ones we do have are much older and closer to retirement age, and quite frankly, more set in their ways. The other statistic is, well, are we getting newer, younger physicians to backfill? It doesn't look to be the case based on the statistics. Physicians with age 35 and under, if you are in a metro market, that represents 14.7% of the total physicians are age 35 and under. In these rural markets, it's 3.7. So you have an older population. So not only is that we have a denominator problem, we just don't have we have a pipeline problem, and we have a resource allocation issue that must be addressed. So that leads to burnout, that leads to depression, that leads to people not wanting to practice medicine anymore, which just makes it much more acute. And interestingly enough, there are more solutions for the state-sponsored business, Medi-Cal, than there is for private insurance, because this market is now will almost be in the future entirely serviced by clinics that are either rural health clinics, government-sponsored, or federally qualified health centers. The private physician practice in these markets is going to be extinct or close to extinct once these physicians age out. Which it sounds good that the government is providing the motivation to bring these clinics into those areas, provide care, but they're really geared towards the Medi-Cal population. So as a private health plan insurer, we are now having to work with these clinics, which is not a problem, but they're not really geared to the private insurer. They're really geared to the Medi-Cal population. That's kind of their mission. And I say that generally speaking. There are a few examples where that would not be the case. But as you try to create an HMO in those markets, the sophistication's not there. You can't capitate them. You can't delegate them. And Marsom can talk a little bit about that. I'll give you one reason why. You would think that intuitively most of these clinics might want private pay. Pays pretty good compared to Medi-Cal. That's not really the case, though, the way the reimbursement works. An example would be if you were a private practice physician seeing a Medi-Cal member for an office visit, you might get $35 for that visit. But because the enhanced reimbursement the government provides these rural clinics, there would be situations where you could receive up to $300 for that same visit. A commercial private pay reimbursement somewhere around $120. So they actually do much better seeing more Medi-Cal members, which is kind of counterintuitive, but that's because they're reimbursed on a cost-based formula. And so that is a predestined amount, and it creates the incentives to really look to service the Medi-Cal population, which is a good thing, particularly now that we expanded eligibility requirements and there's a great demand for those services. But it does create a little bit of a problem for the private insurers like me that are trying to work with these FQHCs. The other piece I want to just mention, what you see in your claims costs sometimes is that most of the growth in these rural healthcare centers are provider-based or hospital-based. So you'll find that in these rural markets, you're finding large systems that are well capitalized will come in and begin to lease or operate the hospital. And attached to that hospital are a number of rural health clinics. And typically, as you know, when you get a large hospital system that's running things, the price tends to increase a bit for you. And so where it's growing for private insurers, these rural health clinics that are provider-sponsored, they're more sophisticated because now they have a large system that can help them grow. But the trade-off there is you're generally going to see higher costs because the reimbursement demands are going to be higher from these larger systems that you see today in California. So there's a silver lining, it is going to cost more because of these systems. So why are these systems coming into these rural markets? Because most of the hospitals there struggle. They just can't survive on their own. The capital requirements to be a hospital provider is much different than it was in the 1940s and 50s when most of these district hospitals were built. You want electronic health records. You want patient safety. You want the best in your equipment. You have boards that are that's not their primary job. Their primary job is the UPS driver, but they sit on the board. So the level of sophistication to help guide and transition a rural hospital or district hospital into the new era of expectations, the management's not there, the governance isn't there, and definitely the capital's not there. It costs a lot of money to do these things, so that your community has a resource, and it's a source of civic pride. So if you look at just my market, 3 hospitals in the last year have converted from being independent to being part of a larger system. 1 hospital closed altogether. So when these consolidation happens, we're getting back to the point where, back to the financial piece of this. Yes, new rural healthcare centers are good. They create the capital to bring more physicians into town. The big systems can do that. They're well capitalized. But you get back to the point now where you're back to a single source. You're entirely dependent on a single source to provide that resource for you. And when you have a single source, you typically will see price inflation with that result. So the market is changing again. This is just purely from a network perspective. I know there's some exciting things happening with telemedicine and things of that nature, but this is where the rural market's going. This is the challenges that exist and you'll face. So I just want to leave you kind of some background in terms of what I see every day, and it is a consolidation, a necessary consolidation, and it does have inflationary challenges. So while we're trying to create access points, there are some challenges to that as well. So I will stop there and leave the rest to my colleagues here, and then if there are any questions, I'm happy to answer those. Thank you.
Good morning, everybody. I'm Shelley Roulard. I'm the Director of the Department of Managed Healthcare. I'm really happy to be here with all of you today. I'm going to talk a little bit about the department and kind of what our role is, since I know that there's a number of new board members who may not be real familiar with the department. I'm going to talk about how we review networks for network adequacy and some of the components that go into that. I'm going to briefly mention telehealth and how the department is addressing issues around telehealth and incorporating that into the networks. And a little bit about workforce development, because obviously, as Aldo just pointed out, that's a real issue for the rural areas. I'll start with our mission statement, which is to protect consumers' healthcare rights and ensure a stable healthcare delivery system. We are definitely a mission-driven organization, and I'm really proud of the staff in every department, every unit within my department that really believes in this mission and works every day to try to make the healthcare system work on behalf of consumers. This is just a real brief snapshot of some of our accomplishments, and I want to highlight a couple of particular points. There are 26 million Californians that are enrolled in the health plans that we regulate. We license and regulate 123 health plans. 75 of those are what we call full service, which is basically health plans, and then 48 are specialized, which are plans like dental and vision and behavioral health and chiropractic health plans. Since the department was created back in 2000, we've served over 2.1 million consumers through our help center, and I'll talk a little bit about that in a minute, which is where we help people get the care that they need. I want to also mention that we conduct rate review in the individual and small group markets, and that was established as part of the Affordable Care Act. So what do we do? What does the department do? So as I said, we're the regulator of all full service and specialized health plans. That includes all the HMOs, as Kathy mentioned, and we also have a number of large PPOs and EPOs that we regulate as well. So all the Anthem Blue Cross PPOs and Blue Shield PPOs are under our jurisdiction. And a number of health plans have been migrating some of their business from the Department of Insurance to the Department of Managed Healthcare over the last few years. Pardon me, I'm coming off the end of a cold. We do regulate health plans that serve the large group market, as well as the individual and small group products. That includes Covered California and some of the private exchanges as well. We also regulate most of the Medi-Cal managed care plans. So all of the commercial plans that participate in Medi-Cal are under our jurisdiction, as are the local health plans that are established by their local county governments. There's one exception, which is the county organized health systems, which is the single health plan in many of the counties. We do not regulate them, and they're specifically excluded from having to be licensed by the department. As I said, we regulate various specialized plans, and we license and review the financial solvency for Medicare Advantage plans. So CMS has responsibility for overseeing all of the networks and general operations, but our department does financial solvency reviews, ensuring that the Medicare Advantage plans are paying claims timely and accurately, and that they have the financial reserves to be able to deliver health care to those beneficiaries. What we don't regulate are products regulated by the Department of Insurance. And I should mention that the Department of Managed Healthcare regulates about 96% of the commercial and public health insurance market in California. CDI has about 4%. And most of those products are your traditional indemnity products and grandfathered plans that were in existence before the Affordable Care Act took effect. We don't regulate Medicare fee-for-service coverage. Obviously, that's jurisdiction for the Department of Healthcare Services. And as I mentioned, the county organized health system plans are explicitly excluded from having to be licensed. We don't regulate ERISA self-insured plans. We don't regulate your self-insured PPOs, although we do regulate all of your fully insured products. Regarding private health exchanges like Covered California or CalChoice, we don't oversee the administration of those programs, but we do regulate the health plans that are participating on the exchanges. The department's funded solely by assessments on the health plans. We don't get any general funds. Occasionally we'll get some federal funding to do some specialized programs. When the ACA first got passed, we had some money to set up a consumer assistance program, which is basically to enhance what we were already doing, and also to set up our rate review program, but we have no federal funds. So the assessment is based on the plan's enrollment, and it's a per member per year assessment. 65% of our budget is funded by the health plans and 35% by the specialized plans. And just so for a frame of reference, the assessment for the full service health plan in the current year is $1.74 per enrollee per year. And for specialized assessment, it's 63 cents per enrollee per year. As I mentioned at the beginning, our DMHC Help Center assists consumers that are having problems with their health plan. So if they can't get care they need, or they're trying to find a doctor, or they have a bill they think they shouldn't have to pay, after they try to work things out with their health plan for 30 days, unless it's an urgent situation, they can come to the Help Center and we will try to resolve that on behalf of them, on behalf of the consumers. Excuse me. Our basic goal is to ensure that people get the health care they need when they need it and that they receive all medically necessary health care. The department also administers the independent medical review process, which is where somebody who's been had their care delayed or denied or modified by a health plan can ask for a doctor outside of their health plan to take a look at it and to determine whether or not the service was medically necessary for that person. So we look at denials that were based on a medical necessity determination, as well as a denial that might be denied because the service or treatment is determined to be experimental or investigational by the health plan. In 2017, as the little chart shows, that we resolved about 4,700 independent medical reviews, and overall, in 61% of the times when consumers came to us for help and had an IMR, that was resolved in their favor. So it's definitely worth it for people to contact the Help Center, because the chances are you're going to get the care you need if you do. We also assist providers who feel that a health plan hasn't paid them fairly or timely or accurately. So we do have a provider complaint unit that addresses those provider concerns. All right, now we're going to get into the network adequacy and how the department reviews provider networks to make sure that they can deliver the care that they're supposed to deliver. Although we don't have the authority to choose what a health plan service area is, we do have the authority to approve their health plan service area. So plans must meet all these three standards for any network that they operate in, or any area that they operate in. With regard to network capacity, there is in the Knox-Keene Act, which is the body of law that authorizes us to do what we do. There are provider to enrollee ratios, and for primary care physicians, the ratio is 1 full-time PCP to 2,000 enrollees. The use of physician extenders, like nurse practitioners and physician's assistants, can add another 1,000 enrollees to that particular practice. For physicians overall, the ratio is 1 to 1,200. So including all of the primary care physicians and specialists, plans must have 1 full-time equivalent provider for every 1,200 enrollees. Timely access is relatively new in terms of our being able to actually measure and report on this. Although it's been on the books for 15 years or so. Timely access standards are time-elapsed standards that are in the law that's establish how soon a person should be offered an appointment when they've requested one. And there's different standards for different types of providers. For a primary care provider, it's 10 days. So when a consumer calls up to get an appointment, the office is supposed to offer them an appointment within 10 days. If it's an urgent situation, it's 48 hours if they don't have to have authorization, or 96 hours if they have to get authorization for that. On the specialty care side, it's 15 days. So somebody calls the cardiologist, they should be offered that first appointment within 15 days. Again, shorter time frames if the situation is urgent. For mental health, it's 15 days for a non-urgent psychiatrist visit, 10 days for a non-urgent, non-physician mental health provider, so a licensed clinical social worker or psychologist or other type of therapist. Ancillary providers like laboratories and radiology centers, an appointment should be offered within 15 days for a non-urgent appointment. Geographic access basically is time and distance, and that's obviously a situation a challenge in the rural areas. But the basic standard for primary care physicians and hospitals is that there needs to be a primary care physician, for example, within 15 miles or 30 minutes from where an enrollee lives or works. The same standard is true for hospitals, 15 miles or 30 minutes. Obviously, in some of the rural areas, that's not possible, and so we do offer or allow plans to request what we call alternate access, which is if there isn't a provider within that area, how are they going to ensure that people get the care, and what's the distance or length of time that somebody would have to travel to receive that care. For specialists, there is no specific standard right now. It's really a reasonable standard. So when we're looking at networks, we look at like what is sort of the pattern of practice within that community and how far people typically have to go to see certain kinds of specialists. Same is true for mental health and for ancillary providers. So the process that we go through to determine whether a network is adequate or not is a number of steps that I'm going to briefly discuss here. So we do our assessments by plan, and by product. So like Anthem's HMO in Santa Clara County, we would look at that, for example, or for a large group or a small group or an individual product. When a plan wants to establish a new network or enter into a new service area, we do a complete network review of all of the contracted providers that they have. We look at the three criteria I said before: timely access, geographic access, and the enrollee to physician ratios. In this situation, a plan can't move forward with the network and start marketing it until we approve it. When there's a 10% change in provider names, and really that's a 10% change in the providers, whether it's physicians, hospitals, or ancillary providers, the plan has to file with us that information, and then we take another look at the network to make sure that it's still going to be able to meet the needs of their enrollees. Those types of filings don't require us to approve them in advance, but if we find a problem, then we will be in touch with the plan and work with them to try to figure out how to meet the standards. The department does an annual network review based on information that all of the full service and mental health plans submit to us on March 31st. So on March 31st of each year, they submit their networks that were in place on December 31st of the prior year. That includes all primary care providers, specialists, hospitals, ancillary providers, mental health providers, all of them. We review all those networks for compliance with the network adequacy requirements every year. That means we're reviewing about 100 different provider networks, because we'll look at their large group, their small group, their individual products, as well as Medi-Cal products as well. Block transfers occur when a contract termination takes effect between a plan and a hospital or a provider group that has 2,000 enrollees or more. When that occurs, the plan must file with us how they're going to reassign those members or how they're going to meet the network standards. And before they can proceed with the block transfer, we have to approve that, as well as the notices that they're going to be sending to enrollees to let them know that they're not going to have their provider anymore and where they're going to be reassigned to. We also, moving on to timely access reporting, SB 964 a few years ago established our authority to submit regulations to establish how to determine a rate of compliance for timely access. It's very complicated, and it relies on, again, the health plans reporting to us every year how they have met the timely access standards that I outlined before. We review that and post it on our website, so you can go and look at all the data around what the plans have submitted. So we have currently an APA, Administrative Procedures Act, exemption from regulation while we're trying to establish what the methodology should be for health plans to report and for us to be able to evaluate whether or not the plans are complying with the timely access standards. As I said, it has been a long time in the works. It's very complicated, and we're moving forward, and we've been working with the plans over the last, at least the 8 years that I've been at the department, to try to come up with a methodology that they can use and we can rely on so that we can enforce the timely access standards more effectively. We just released our timely access report for measurement year 2017 at the end of December, and that is on our website if you're interested in looking at that. With respect to alternate access, as I mentioned, when a plan isn't able to meet the 1530 time and distance requirements for primary care physicians or hospitals, they can propose an alternate access, and we look at those on a case-by-case basis. It doesn't apply to specialists because specialists, again, are a reasonable standard, and we have a number of ways in which we evaluate what's reasonable, including looking at what other plans have done with respect to contracting for specialists, and as I said earlier, the patterns of practice of a particular community. So plans do have to file those requests with us for alternative access, and we review them and determine whether to approve them. Again, that occurs primarily in the more rural areas of the state. Briefly, I wanted to touch on telehealth. Because over the past year, we've been participating in a work group with the Department of Healthcare Services and with various health plans to really learn more about how plans use telehealth, particularly around e-consult. Our experience is that very few health plans have filed any policies, procedures, or programs with us with respect to how they're going to use telehealth. Although my understanding is that the Inland Empire Health Plan and LA Care, which are both Medi-Cal plans, are going to be filing something with us in the near future. And it may be because Medi-Cal is now coming up with a methodology for payment for telehealth visits, which has been a stumbling block in the past. The primary activities for telehealth seem to involve mainly specialty consultations, such as dermatology, and certain types of mental health visits. There's been rumors out there that there's a perception that the department is somehow a barrier to plans implementing telehealth. But I just want to assure you that that's not the case, that what we're really wanting to ensure is that telehealth visits aren't going to replace in-person visits, but they're really going to supplement and make expanded access as opposed to replacing in-person visits. And I think a big stumbling block to the broader take-up of telehealth is related to payment mechanisms and what the providers want and what the plans are willing to pay for telehealth visit compared to an in-person visit is different. I don't know if you had an opportunity to see the December 2018 Health Affairs issue, but the whole issue is about telehealth. And one of the articles indicated that the take-up of telehealth by health plans is pretty limited, and that's really been our experience as well. So I'm hoping to hear more from May about how that can be expanded and really enhance access for healthcare consumers. Aldo mentioned about workforce development, and certainly this is a huge issue since the ACA passed and Medi-Cal expanded so significantly. So ensuring an adequate healthcare workforce is obviously top of mind for a lot of people. Although we can't directly affect that, there are some tools that we've used recently to support the Office of Statewide Health Planning and Development, OSHPD, and their Health Professions Education Foundation. So last year, the department was reviewing 3 health plan mergers. CVS was buying Aetna, Cigna was buying Express Scripts, and Optum was purchasing DaVita. And as part of the negotiations of those mergers, we attach undertakings or conditions that if we approve it, then the plans are required to deliver on. So in the CVS-Aetna merger, for example, we required the company to contribute $22.8 million to the Health Professions Education Foundation for loan repayment and scholarships and other workforce development activities that the HPEF does. So they do help to improve access for healthcare in underserved areas by, again, as I said, forgiving loans, providing scholarships to health professional students and graduates who are dedicated to serving those areas. In the Cigna Express Scripts, they're going to be donating $10 million to that foundation. And Optum-DaVita merger included $8 million over 4 years for what it calls its Diverse Scholars Program. They particularly needed to have more child psychologists and psychiatrists, and so they're focusing their scholarship money on those folks who want to go into those fields of child psychiatry and psychology. With respect to capital and, in the rural areas and not having access to that, in prior undertakings that the department made back in the early 2000s, there were funds set up through the Anthem WellPoint merger and the United Pacific Care merger to provide low-interest loans and covering the cost of bonds and things like that for hospitals and clinics, actually all over the state, but as a matter of fact, they're mostly in the rural areas, to help with getting low-cost loans and money for those kinds of expansions or establishing their electronic health records or wherever it may be. So there's still money available in those funds. So if you hear, Kathy, about folks who are needing that kind of investment, then they should definitely contact the department. Last slide, this is contact information for our help center. We do assist CalPERS members who are enrolled in the fully insured plans. If they're in your self-insured plans, we refer them and we warm transfer when we can. So we're here to assist all healthcare consumers in California. Thank you. Oops, sorry, skipped your picture.
All right, good morning, everybody. Is it still morning? Yes, it's still morning. I'm okay. Well, thanks for having me. My name is Barsam Khosravi. I'm a family physician, and I oversee our Medicaid business at Anthem Blue Cross. I don't want to take credit for the commercial side, so Brian Ternan is the president for the commercial side. Every time I'm on a panel, I'm learning so much already, so it's been great to be part of this panel, and we definitely are partnering with both Aldo's organization as well as the DMHC to really ensure we provide adequate access and support the rural counties. So I'll be speaking a little bit about our experience in the rural counties. We've been in Medi-Cal since the 90s, but we recently entered the rural contract with the state, and we'll go through some of our learnings there and some of the opportunities we see with that patient population. Just a little bit about Anthem's Medicaid footprint. We're about 1.2 million members across the state. We're in 29 counties. And each county, as I've learned over the last 11 years being at Anthem, is very unique, and it has its own provider culture and challenges and opportunities. It has its own member and patient opportunities and challenges, and it also has, stakeholders. So we really, when we receive the rural contract, which is the 19 counties in yellow, it does not mean the blue counties are not rural, because some of those overlap with the counties that Aldo spoke about, but formally the rural contract is the counties in yellow. Each of those counties is very unique. So we really, as we were awarded that contract, really wanted to understand the dynamics of every single one of those counties. And it is a large number of counties, so it required a lot of listening, being present, understanding the dynamics and challenges of the counties, and really seeing as a health plan to the rural markets that were new to managed care, how could we best partner and kind of move along this continuum of managed care when a lot of the providers in that region were very new to managed care. Ideas of utilization management and capitation and they're very used to the fee-for-service through the state. So there was a lot of learnings there that we'll talk about, but the key was for us to listen, be present, and try to partner as much as we could with the local community. We talked a lot about some of these issues, so I won't necessarily repeat some of the points that were highlighted. I would say at Anthem, we really, because we're in some of these counties, particularly Butte County and a lot of the rural counties, in both the commercial and Medicaid side, it does allow us to leverage our commercial network, and we've seen that play out a lot in behavioral health. Behavioral health is a challenge across the state. I would say even in LA County, you would think there would be enough psychiatrists for the population in Los Angeles, but so there are certain specialists that across the state we're having challenges with access, and we are looking at partnering with our commercial side and really trying to ensure that there is adequate specialty networks, even if that means reimbursing at a higher rate, at a commercial rate or at a Medicare rate. We'll talk about telehealth. Telehealth is one that Anthem has actually been very involved in from the 90s, when there was the store and forward concept of having physician sites actually present cases to specialists. We've evolved that model, and I'll get to it a little bit more in the next slides. But the key with telehealth is really to ensure that, as someone once said, it works in the ecosystem of healthcare. Telehealth, telemonitoring, a lot of these new technologies are very, they sound very, very promising, but the key is how do they work in the workflow of the physician? How do they work in the life and the culture of the patients? And to make sure that they get adequate buy-in from both stakeholders. Because if you have a new technology and the uptake isn't there, which we found that to be the case in the commercial side, it's not going to be as effective as we'd like it to be. Physician recruitment, and I should have changed the word physician, because even though I'm a physician, I tend to believe that we can get a lot of healthcare done without the physician. I don't know if there's a lot of physicians here, so I don't want to talk about too much about physicians, but I sometimes feel like we rely too much on the physician and not enough on the other healthcare providers. And I think with the rural counties and even across the state, California Healthcare Foundation just published a map of California, and it looks at physician shortages across different counties. And it's very interesting that, the solution might be that we recruit non-physicians in a lot of the counties, nurse practitioners, physician assistants, LVNs. There's a lot of care that can be done without necessarily the actual physician being in the room. And so we want to partner with other health plans and the local counties to ensure that we have, not only the telehealth solution, but also a provider recruitment solution. And to Aldo's point, there is a challenge recruiting clinicians to the rural markets. We've seen that as we've gone and visited the major clinics in our rural markets. They do tend to be, not straight out of training, been there for decades, and which is positive because they are embedded in the community, and it is the old-fashioned, my physician has taken care of me and my children and my parents. So that is a nice kind of a nice piece of healthcare that maybe is being lost in the new model. But I do think that the physician access is a challenge, and we need to find different ways to maybe have other types of clinicians or even train clinicians. We were talking to Butte County recently about residency programs, building local training programs so that we don't have to, and Kaiser does this really well, having trained at Kaiser as a resident. If you train at a facility as a clinician, you tend to stay there. So having more training opportunities kind of upstream rather than having them come out of a UCLA, for example, and then trying to get them into a rural county. I'll talk a little bit about our care coordination. We do a lot of population health and other types of programs in the rural counties, and we'll talk a little more about that. And I briefly talked about partnering with local stakeholders. Definitely think in the rural markets we're seeing that the importance of the public health officer and the county presence in the rural markets is very significant. So we really focus on partnering with the county themselves and particularly the public health department, which some of the urban markets it's not as much of a partnership. And then the importance of the hospital system, as Aldo mentioned, and the realization that sometimes in these counties there's only one hospital within hundreds of miles. And so the importance of understanding the challenges with that hospital, partnering with those hospitals, not always easy as a plan, but we really are trying to understand the challenges and work with those hospitals to take care of those patients. And then, as mentioned before, behavioral health, probably the number one issue in the rural markets as far as access and as far as prevalence of disease and substance use. We'll talk a little bit more about that as well. This is just that our telehealth program at Anthem is present. I wouldn't say it's been having a huge uptake at this point. We did recently launch this program called Life Health Online, which is an app that gives access to members. It's mainly right now for urgent care. It's not primary care. It's urgent care, and we're looking at launching telepsychiatry and telepsychology, which is one of the areas that we've been hearing from the counties in the rural markets that is needed. To the points earlier, we are partnering with the providers to really let the members know that this is available. the time that it was used the most, as far as a silver lining, was the recent wildfires in Paradise. That was a pretty significant county for us, Butte County, and we really rallied to get the Live Health Online access up there because of the physician challenges. We even had a kiosk placed up there so that the members could access urgent care and psychiatry. There was a lot of need for grief counseling, so we had psychologists being connected. So that was kind of our first introduction to Medicaid telehealth, but there's a lot more that has a potential. I think the awareness, the marketing, the early adopters, and just getting the word out that this is a safe and useful tool has been a challenge for our commercial side, because this tool has been on live in the California space. But on the Medicaid side, we're starting slow. We want to really partner with our key provider groups and see if we can ensure that members are using this when they need to, mainly right now from the urgent care side and for psychology appointments, setting up psychology appointments and getting psychology care. A little bit about some of our programs that we have in rural counties, and these are programs that are specific to our rural county markets. We have a readmission reduction initiative. So, I know that readmissions is a big challenge in all markets, but in the rural counties, we feel that we really need feet on the street. So we've hired local nurses, particularly in Butte County, to really identify members who've been in the hospital 3 times in the last 6 months, and actually engage the member at the hospital and work with that member to go to their PCP appointment, to understand the medications they're taking, to do a home visit. So it's a very local, feet on the street type of program, and we've seen actually very significant results. The challenge is it's a little bit difficult to scale, but we feel in some of these rural markets that the old telephonic model of care coordination is not necessarily the answer. I won't go through all of these programs, but a couple on the bottom. Safe Choice is an important one around substance use. So, as a plan, I feel like it's our responsibility to really monitor the opioid, not only monitor, but really act on the opioid epidemic that, particularly in the rural counties, is a huge challenge. So we were the first plan to really go to the state and ask for what's historically been called the pharmacy lock-in program. And what that means is that if a member/patient has accessed opioids in several different pharmacies with several different prescribers and potentially paid cash, that gets flagged in our system, and we then ensure that member can only access those types of medications through one provider and one pharmacy. And we also engage the physician prescribers to our medical directors write and call the prescribers to ensure that they understand the CDC guidelines. So we have a whole program around identifying those high utilizing members and ensuring also that they get the care, the pain management care and other types of care that they need with the lock-in program. We call it Safe Choice program. So that's an important program for us. We want to launch it in more counties. We're working with the state. I think we recently got approval to launch it statewide, but we've been trying to add more and more counties. But it's an important responsibility of the health plan, because we have access to pharmacy data and physician data to really make an impact. And I know there's some models out there with Partnership Health Plan and other plans that have done this really well. Emergency Department Reduction Program. So we do have a program where we get census data from the emergency rooms, and particularly in the rural counties, we have this live at Amador and Placer. And the hospital census that comes to us, we then do face-to-face visits after an ER visit and ensure, particularly the ones that have been in 3 to 6 times in the last 6 months, that we do a home visit and we engage with that patient member to make sure that we prevent future ER visits and ensure they access the primary care system. Some of the areas of social determinants. So on the Medicaid space, there is a program called Whole Person Care, and I don't know if you are familiar with Whole Person Care. It's part of the 1115 waiver. It was a $6 billion fund initially invested that goes through the counties that really addresses homelessness and social determinants of health. And it encourages health plans and the county to work together to ensure management of the most complex patients in the counties. Governor Newsom recently has come out and said that he wants to fund this program another $100 million to ensure additional solutions for homelessness and housing. So it's a program that is county specific. We're currently in 9 counties across the state, and 3 of those 9 counties are in the rural markets, Placer being one of them, and 2 others. So it's one that we're committed to, and it really helps with not only the funding, but the support of working with the county and all the health plans within the county to address the needs of the patient. Some additional programs, I won't go into too much detail. The practice consultants is one where we felt like the clinics, the ones that Aldo spoke about, and I worked at a federally qualified health center, they definitely have staffing challenges in these clinics. They have workflow challenges, scheduling challenges, and we felt that it was our responsibility to help support these clinics in a different way. So we helped fund what we call practice consultants or nurses that are Anthem staff that actually get embedded in some of our larger volume clinics, particularly in the rural markets, to help with workflow improvement, process improvement, scheduling, getting members to come in and get their preventive care. So just an added set of hands, and it also helps build partnership and allow us to understand what the needs of the clinics are. And it's been a really good model that we've launched statewide and in addition to in the rural markets. Just on the last point, transportation is a big issue in the rural markets. There's no easy answer for transportation. I mean, I took a lift here, and I think it was pretty easy for me, but I know for the rural markets, it's very challenging. We have some transportation vendors, not always, viewed favorably by various counties. We've heard that feedback. We're trying to become innovative with different types of transportation, but there are some significant distances that need to be traveled in some of these markets, particularly if there's a need for specialty care. And so we are constantly working with our county partners to understand those needs, whether it's behavioral health transportation needs, physical health, and ensure we have the right types of systems in place to make sure that transportation is happening. Maternal child, we mentioned already, but that's an important area across the state. We have a high-risk OB program, which looks at not only high-risk moms, but also the babies that have potential challenges in the NICU. We have a case management program, and we have launched it in the rural markets, and it is an issue, particularly pregnant women who use opioids. That has really been a challenge as far as having challenges with the baby once the baby's born. So in closing, I think the key is partnerships. We cannot do this alone in the rural markets, and to be transparent, the markets, they're not always super welcoming of managed care and health plans, so we understand that, and we're trying to change that perception. It's not going to happen overnight. It's been 3 years, and it's still not happening overnight, but we're working really hard to understand the needs of the various stakeholders in these counties and create solutions that are sustainable. I would say the one area that we need to work more on is the recruitment piece. Recruiting the workforce that is needed in these counties and what that workforce will look like, which to Aldo's point, it cannot look like the current workforce. It has to be a new model that is effective in those markets, because the old kind of physician clinic model might not be able to address the needs of the future patients in the rural markets. So with that, I'll turn it over. Oh, I'll keep your picture.
Well, thank you, and thank you all for having me and inviting me to speak on this panel. Like Barsam, I'm really impressed and happy to hear and learn from my other fellow panelists here. My name is Mei Kwan. I'm the Executive Director at the Center for Connected Health Policy, and as you can see from the JD, I'm an attorney, so I always have to start off with a disclaimer before I speak. I'm also grant-funded or funded by government, the federal government specifically, so they really wish me to put out a disclaimer here so people don't think I am giving legal advice. CCHP does not provide legal counsel. We always advise people if they're looking for a legal opinion to seek out counsel. Also, if I happen to mention a company or a piece of equipment, know that neither I nor CCHP has any type of business arrangement or affiliation with such company. Who are we? Why should you even listen to anything I have to say about telehealth? So I am with the Center for Connected Health Policy, and we actually were funded with a grant from the California Healthcare Foundation to focus in on California telehealth policy back in 2009. An opportunity to become the National Telehealth Policy Research Center through a grant from HRSA became available in 2012. We applied for that, and we've been serving in that capacity ever since. Now, what does that mean? Well, basically, we are in a grant program with 13 other entities. 12 are regional resource centers, so they cover specific states. California has its own regional resource center, the California Telehealth Resource Center. What they do is they provide technical assistance for people who are interested in starting a telehealth program, or they might have a telehealth program now. They are the boots on the ground, program operational level folks. They help with everything from what equipment should I start considering? How do I do workflow? How do I do billing? They provide that type of service. There are 2 national resource centers. I'm one of them. I'm on policy, so I assist the regional resource centers when questions on policies or laws or regulations come up and they maybe can't answer it. They refer them to me. There's also another national resource center that's focused on technology. So folks who have questions on telehealth software or the actual equipment can contact that resource center. They're based out of Alaska. But all 14 resource centers work collaboratively together. So I would say if you just reach out to one, you get the other 13 also. And I would say about 99.9% of the time, somebody has an answer among the 14. And if they don't have the answer, somebody usually goes out and tries to find it. And most of the time, they're pretty successful. Although when we get into the policy, sometimes it gets a little fuzzy, and there may not be a concrete answer out there. One thing that we do as the National Policy Resource Center is that we actually cover all 50 states in the District of Columbia. So we track all of the telehealth-related laws, Medicaid policies, and regulations for all 50 states. That is a snapshot of our website. We keep that information updated. We do 2 major overhauls every year, one in the spring, one in the fall. And we put that information on our website in an interactive map. So say you're interested in what's going on in Texas, you click on it, it brings up all that information. We also track any pending federal legislation or state legislation as well. That's updated a little more frequently as bills go through their process. So I'm not going to spend a lot of time on this, and I want to make sure there's plenty of time for questions. And Kathy and Aldo and the other speakers have also touched upon this there is actually a great need for health services, specialty care, sometimes even just primary care services in rural communities. And one of the solutions that people have looked to, or at least a tool to address those needs, has been telehealth. And that's not anything new. That's actually been around for close to a little over 2 decades. Back in 1997 was when Medicare first started reimbursing for telehealth services, but they were limited to providing those services in rural areas. And that's still pretty much the Medicare policy right now. So the use of telehealth in rural areas is not anything new. It's not something that's happened in the last couple of years. It's been around for a while. But what's actually sort of prevented it has been first, probably the technology itself, in that back in 1996, 1997, if you think about like what technology you had available, perhaps it wasn't quite there in providing the services that were needed that it is now. Also, so it was kind of, you kind of understood why maybe the policies were a little bit more restrictive. However, as that technology has evolved, the policy hasn't been able to keep pace with it. So I'm just going to go over briefly, because we've used the term interchangeably here today, of telehealth and telemedicine. So sort of rule of thumb, what we look at the center is that telemedicine is the use of technology to provide direct healthcare services, whereas telehealth has a broader definition. It can include education, it can include public health information. It's a little bit broader than the telemedicine definition, and that's what it's usually addressed as in most places in the country. Although you do still have definitions sometimes that vary from jurisdiction to jurisdiction. There are 4 modalities for telehealth. The live video modality, which takes place in real time, most people are familiar with. Store and forward was mentioned by Barsam. That is a capturing information and sending it to a provider, and they're not looking at it immediately, they're maybe looking at it at a later time, and the patient's not directly involved with that second provider at the moment. And then there's remote patient monitoring, which is the continuous monitoring of a patient, and it can be in real time. Think of a ICU unit. You may not have your intensivist on site with the patient. They're monitoring from a different location. Or it could be in non-real time. That could be a patient at home, perhaps with hypertension, who is taking daily readings and sending them to the provider. The provider is likely not looking at it as the readings come in, but are looking at it maybe at a later time. And then there's mHealth, which encompasses really all the other 3 modalities in some way. It's just the use of some mobile device to access some type of health service. As I mentioned, telehealth is a bit more encompassing, and that is the way that it's starting to be looked at now, is looking at it beyond just providing direct services to a patient in some way. It is being looked at as, how can you use it in the public health arena? How can you use it for education? How can you use it for training? This is not an advertisement for UC Davis, like I said, no affiliation. But I want to put this out here because this was a nice, handy sheet where they list all the specialties that they provide using telehealth. And as you can see, it's quite a bit. It goes beyond maybe what a lot of people might be used to hearing, such as mental health services, or if you're talking about storing for dermatology or ophthalmology. In that they have, I think it's roughly around, over 30 different types of specialties which they use telehealth for. However, the use of telehealth has been impeded by policy barriers. Now, I'm just going to talk about policy barriers today, but there are other issues that impede the use of telehealth. Barsam actually hit on like a big one. He was talking about workflow and also a cultural type of identification with it, whether it's actually quite very disruptive to the workflow within a medical setting because it is doing something different. There's also education issues on whether patients are aware of telehealth and to ask for it, or their familiarity with it. They might view it with suspicion. So there are all these other factors that aren't necessarily related to policies that do impede its use, but policy does create significant barriers to overcome. One of the big ones is reimbursement, and reimbursement is broken down into not only that you get paid, but who gets paid and when you can get paid. A lot of the existing telehealth policies are broken down in specific areas as to which providers are allowed to use telehealth and get reimbursed by a certain payer, where that service takes place, usually in a clinical setting, and how it's used, like for what services. So they may limit it to specific specialties. But there are also other policy barriers that could impede the use of telehealth, such as prescribing, and that plays a significant role, especially when you're talking about using telehealth to treat substance use disorders. One of the ways, especially for an opioid addiction, to treat that is through medication-assisted therapy, which is the use of not only the therapy side for behavioral health, but also a medication prescribing side of it where you would use controlled substances. And telehealth, the way you use that, is very limited as far as how you prescribe those controlled substances. Licensing is also an issue that has impeded the use of telehealth because one of the great things about telehealth is borders really don't matter. You can cross state lines and provide services. Distance becomes like almost a non-factor. But you have these licensing issues that crop up for providers if they have to have patients in other states. And then other legal issues that play into this are privacy issues. How do you address telehealth and HIPAA and privacy and security laws that might be specific to states, and also malpractice coverage. Does your malpractice coverage for your provider cover those telehealth delivered services? Will it work in those other states if you happen to be operating in those states? And the greater concern that I hear a lot from providers is, well, what's going on with malpractice and telehealth? Have a lot of people been sued? And I can say, at least on that end, actually not a lot of cases involving telehealth and malpractice. A lot of them are around radiology, but not around the technology itself. However, I think that's kind of a numbers game. most likely the more telehealth use there is, most likely the amount of malpractice cases will increase. So what are some of the recent policy changes? If you had asked me to give this presentation about 2 years ago, I would have said, you know, on the federal level in California, it's been kind of stagnant, not a whole lot. Medicare around telehealth reimbursement is actually one of the most limited reimbursement policies out there. But what Medicare has done over the last 2 years is they are restricted by federal law. So in order to change their telehealth policies in Medicare, you do require like an act of Congress. And those bills have not really moved a whole lot. But what Medicare has figured out is if we don't call it telehealth, but you're using telehealth technologies, but we call it something else, those laws don't apply to us or apply to this because it's not telehealth. We have called it something else. So one of the modalities that I mentioned, remote patient monitoring, that continuous monitoring, they called it chronic care management. So it's not telehealth, it's chronic care management. So all those telehealth restrictions do not apply. They have other limitations, but at least the telehealth restrictions in law would not apply for that reimbursement. They've carried on that type of thinking into 2018 for policies that now take place in 2019, in that they're called it internet communication-based technologies. And there are 3 new services that they are reimbursing for that, again, use telehealth technologies. Because it is not called telehealth, they are not required to follow those restrictions and limitations underneath federal law. So they are a virtual check-in, which is a quick check-in with a patient for that does not result in a visit 7 days after the check-in, or is not a result of a visit from a visit that took place 7 days before. So it's that quick check-in you do with your doctor of like, hey, you know I have an appointment coming up, but that rash seems to be healing nicely with the medication you gave me. Do you think I need to come in? And you know, the doctor will like speak with the patient, assess them, and if they feel like they don't need to come in, they say no. Or you know, like the medication for my child that you give them for strep throat or the ear infection, it seems to be clearing up. They're feeling a lot better. Do you think it needs to come in? And they say no. They can now get reimbursed for that underneath Medicare, and they can do that for a live, even by phone, check-in, or the asynchronous version, the store and forward version, like the skin condition example I gave, that if the patient took a picture and emailed that to their doctor, and the doctor looks at it and says, you don't need to come in, they get reimbursed for that. And that's probably a service a lot of doctors have been giving, but not getting paid for. So Medicare is now saying, if you use these technologies and if you use the phone, we will pay for it. The other thing that they are offering to pay for was something that Shelley mentioned, was something called e-consult. And I know there's a lot of different definitions people have. It's like telehealth, different definitions on what an e-consult is. The way Medicare is using e-consult, and the way a lot of people here in California think of it, is a provider-to-provider consultation that's taking place not in real time. It's basically like curbside consult, very highly elevated over a secure system with a lot of information. And Medicare is saying, we will reimburse for that. And the interesting thing is they're saying, we will reimburse at both ends. We'll reimburse for the primary care provider's time, and we're reimbursing for the specialist time. So these are some of the things that Medicare has taken upon themselves to do. They're not calling it telehealth, because if they did, they would be restricted by federal law on like where it could take place. But it is using telehealth technologies. Now, a couple of things. I said that it would take an act of Congress to eliminate some of those limitations in the Medicare program. Last year, they actually did do something in Congress related to telehealth policy, but it was buried in other bills. So it wasn't a telehealth bill, but it was part of like Bipartisan Budget Act. They had something where they freed up some of the locations on where telehealth could take place, but for very specific services. It's end-stage renal disease, where they allowed the home to be a site where you can receive some end-stage renal disease services, and also for acute stroke, where they expanded the types of location where acute stroke services could take place, and you can get reimbursed for that telehealth services. One other thing that also happened was underneath the Federal Support Act, which had some telehealth changes in there related to substance use disorder services. Again, they freed up some of the location allowing the home to be a site where you can receive the mental health service side of things related to substance use disorders. So you see these pinpointed changes taking place in law, but you also see these wider changes taking place administratively. One other federal law change that I wanted to mention is that Medicare Advantage plan. So Medicare Advantage plans right now pretty much are just required to follow what's in the fee-for-service sides of Medicare related to telehealth policy. They've opened that up. Basically, it's still kind of in the regulatory side where they're getting feedback on what they're proposing, but what they have proposed is to allow Medicare Advantage plans to set your own telehealth policies, and we will cover it. Currently, the policy for Medicare Advantage plans is, and if it goes beyond what's the very limited scope in the fee-for-service side of things, then we will, you will have to pay for it, or the enrollee would have to pay for it. So they're offering to expand that now, but like I said, that's still in the regulatory phase, and the policy changes would not kick in until 2020. On the state level, again, if you had asked me to, well, even just last year, early last year, give this talk about what's going on in California related to telehealth policy, I would say we've kind of stagnated. I said I track everything that goes on in all the other states as well, and a lot of states had started pulling ahead of California, which was a shame because California, back in the 1990s when the changes were going on in Medicare, California was one of the forerunners on telehealth policy, and it was actually a trailblazer. But it sort of stalled a little bit starting in the 2010s. However, it's picked up again, and there could be a variety of reasons for it, but it's a very encouraging sign. And one of the most encouraging signs is with the Medi-Cal program. So California's Medi-Cal program was what they did for reimbursement for telehealth on the fee-for-service side. Again, was fairly limited. And the reason I concentrate so much on like the Medicare policies and the Medicaid policies and Medi-Cal in particular is that sometimes those policies are replicated by payers too. They just copy what that telehealth policy is in Medi-Cal and they just transfer it over to their own payer policies. So if you had a limited telehealth policy underneath Medi-Cal, it could possibly be replicated to other payers as well, and you just have like this very restrictive policy out there in the state. However, last year, Medi-Cal sent out a draft proposal update to their provider manuals related to telehealth. And one of the most exciting things that they are proposing to change is that they would allow a Medi-Cal enrolled provider to decide when it was appropriate to use telehealth and if they would use it via live video or store and forward. And they would reimburse for it if it was a service that Medi-Cal typically covered. And if it was a service that didn't require some sort of in-person type of element that was involved. So that is actually very radical because a lot of Medicaid policies, a lot of telehealth policies usually have it limited to something like we will only reimburse for live video for all covered services, or they would say we would only reimburse for these type of services either by a specific CPT code or specific specialty. Medi-Cal is now saying, you know, the provider, this is another tool in your toolbox. Use it as you see appropriately. And that's always been a position of the center in that it should be left to the provider to decide whether it's appropriate or not because they're actually in that specific situation and they know whether it would be appropriate to use for that patient, for that particular condition. So Medi-Cal is offering now to do this. It's not finalized. Like I said, it's a proposed policy, but they seem on track to keep that proposal, and they're looking at around spring this year to like finalize the policy. There are also other things I've heard and also been contacted by parties who are likely going to introduce telehealth legislation this year. And there were gaps in that Medi-Cal proposal. One of the things that they were not reimbursing for was remote patient monitoring. So there's an interest in addressing some of the gaps that were in the Medi-Cal policy and possibly some legislation that would impact private payers as well on that end. One other thing that I want to touch upon that is influencing, I think, a lot of these telehealth policy changes and that each of the speakers has mentioned before is the substance use disorder and the opioid crisis that's out there. There's a lot of interest in how you use telehealth to do that, mainly on sort of the counseling, behavioral health side of things, because that is, I've always called mental health sort of the gateway introduction specialty to telehealth, because a lot of people, when they hear about telehealth, a lot of times, if they're really not familiar with it, the first question is, how do you do that? You can't touch the patient. And I always bring up mental health. I said, well, what about mental health? You probably shouldn't be touching the patient during that type of interaction. So you can use video for that. And that eases people into like starting to understand how telehealth works. So that is being looked at, as I mentioned earlier with the Support Act, as how you use telehealth and like relaxing restrictions around that may exist both on the federal and the state level. But also on the prescribing side, one other federal change that has been made that I mentioned was one of the issues of using telehealth to treat substance use disorder, particularly an opioid disorder, is that you may need to use a controlled substance to treat that condition, and telehealth is very limited in how you can prescribe controlled substances. It's federal law. A lot of you might be familiar hearing the term Ryan-Haight Act. That is where the telehealth limitation comes in. There's only 6 very specific scenarios where you can use telehealth to prescribe without seeing that patient in person first, and it's very limited. But one of those exceptions that they allowed is for a DEA registry. Now, Ryan-Haight Act, I understand, has been around. It was a little bit before my time since I started working in this field, but like 8 or 9 years, and there's always been that element for the DEA to create the registry, and they never have. They've always said, we'll get to it, but they never did. It's a registry where presumably you get on. It means that you've been vetted and you're okay to prescribe via telehealth as long as you're on this registry, but they never created it. Congress last year said, DEA, it's time to create it. So have final regulations done by this year in 2019. So that presumably will help ease things as well, or allow for greater opportunities to use telehealth to prescribe. Now, one caveat for that is they didn't tell the DEA how to do that, so I don't know if the DEA will come up with something that was pretty onerous or restrictive where providers may say it's not worth my time and effort to get on that registry. So, and that's it. That was very quick, but we want to save time for questions, I think.
Thank you, May, and thank you to the panelists. And Mr. Jones, President Jones, we're going to start off with one question that we will ask 1 minute only for each panelist to address, and then I'll turn it over to you.
Okay.
And you can lead the discussion with the board.
Okay, thank you.
So our question is, we've seen a lot of the challenges. What are the most promising solutions to improve rural health care in California? I'll start with Aldo.
Well, I do think that telehealth, telemedicine has a role, but I think it's a stackable solution. In and of itself, it won't solve the problems. And I think telehealth, telemedicine is becoming kind of more of a retail, consumer preference, convenience item. That's where you're really seeing the growth. But I do believe it has a place in the rural setting. Interestingly enough, I don't have a lot of optimism here. I do think that California needs to look at its corporate practice of medicine laws that prevent lay folks from employing physicians. I do think that, especially in the rural markets where you provide greater freedoms to some organizations to be able to employ physicians in those markets, particularly for their private pay. So to me, you might have to change the rules just a little bit so to allow hospital systems who generally are trying to be helpful to recruit physicians in those areas, and they spend a lot of their resources subsidizing physicians in those markets, but they have to run through a lot of hoops, a very expensive way of doing business. If they had some limited ability to employ with some oversight, I think that would really change some of the motivations and obviously create more resources for members to access. Keep it to a minute.
Well, this is a tough one for me, being a regulator of health plans, because I don't really have the answer to this question. I think that, you know, my department operates within the confines of the Knox-Keene Act, and it's a box of law that we're pretty restricted to. But I think one of the things that we're starting to think about is how to be more flexible in our regulations, and starting to think out what we can do within that structure to support solutions in the rural health. So, for example, one of the things I mentioned was about, you know, getting money for workforce development through some of the mergers. I mean, that's not something we're technically authorized to do, but through the process of negotiation, you know, you can get things that you might not otherwise be able to get. So I look forward to hearing the solutions from the rest of the panel, frankly.
That's actually I was going to mention the capital that you had spoken about, Shelley, because I do think with the amount of dollars that are now in this fund, that I think is a great opportunity. And as you mentioned, Anthem has this capital as well that is low interest loans. You know, there is a lot of capital that could be used the right way. I think the important piece now is to say, how do we best, in a coordinated way, maybe having even a third party, maybe California Healthcare Foundation or someone, think through how do we best use these dollars where it's a sustainable workforce solution. I think the way physician recruitment has been done in the past, having been married to a physician who received a loan repayment, which was great. I mean, she worked in the county in LA, which isn't exactly rural, but some physicians do get motivated to move for some of this reimbursement. But I think we have to think, now that we have enough dollars here, which it seems very substantial, and I applaud you for having identified that as a gap, and then having the Anthem piece and even other plans as they're coming in, how do we use this money in a sustainable way to recruit the right type of providers for the rural markets? Because I think if we want to just be careful how we use the dollars. I do think that's the most promising, at least from what I've heard. I wish it was something that we were doing at Anthem, but I having heard that, I would echo that would be a great opportunity for the plans to partner with kind of folks that have been doing this maybe even outside of California, where this is done more effectively, particularly in the rural markets, and make sure we spend this money wisely.
You probably know my answer, so it will be telehealth, but I don't think. But I agree with Aldo. It's not like the silver bullet. It's not going to be the magical thing that solves all the issues. But it is a piece of it, but also not in just providing healthcare services. I think one of the things that I've heard from rural providers when they do have telehealth accessible to them is that they really appreciate having that access to other professionals who can help supplement them in some ways. So I think one of the things addressing the workforce issue is maybe have a policy, and we've discussed this at CCHP with different policymakers, is maybe not having telehealth, as they say, be a full credit for loan repayment, but maybe a partial credit if somebody is providing a service to a rural community with telehealth in some way, and that they get some type of credit in delivering that service to those rural communities. But I would say telehealth is definitely a factor, but I do agree with Aldo is that it's not going to be the only solution for the issue.
And now, President Jones.
Yes, okay.
Take it away.
Okay, thank you. Yeah, Mrs. Taylor.
Well, thank you very much. Thank you. I appreciate the panel's presentation. It's a hugely complicated issue, and our members that we serve, we have a lot in the rural areas, and it's one of the things I hear about the most when I go out and talk to my members. So I had a lot of questions, but I'm going to try to pare it down so other people can have a chance to ask questions too. First, I wanted to say to Aldo, I know your brother. Felix.
Okay.
Yes. Yes.
Because it matters.
Yes. And Brooke said hi. So first on the telehealth, I think one of the questions I had is, as we implement telehealth, there's two questions actually. For the rural areas, and say the access gets better and more people are using it, how does that impact those reimbursement rates? Does that make that reimbursement rate go up so that it would be almost like seeing a doctor? Does anybody have an answer to that? I don't know who would answer that.
I can give you an answer from, again, my prism here. Where I see telehealth working, I think we touched a little bit on, it's very disruptive to the office flow. So adoption is going to be a big issue. A lot of physicians don't want to participate because it's a trade-off.
Right.
They're taking that time up and the office becomes less efficient. And typically, they receive less reimbursement than they would in a typical office visit. In some cases, they receive nothing, so they'll get more than they get today, but I still think it's going to fall short, at least on the private insurance side, of what they might receive for a face-to-face visit. And again, where I see it really growing is my world is broker world, it's private insurance. This is private insurance at CalPERS. Is the consumer preference to use Live Health Online, to use Teledoc, all those features, and it's really I'm watching the member convert to a consumer now. Retail is big, which is why you see CVS and Aetna emerging, right? Retail is trying to find a place there because what they're looking for is access, but not more access. They want different access points into the system, not just their doctor's office.
Right.
So it's a long way to answer the question, but I do see the reimbursement over time creeping up. The question is it enough of a trade-off based on the disruption you're going to have in that practice, and the people you have to hire maybe to keep the equipment going depending on what you're doing? It exists today informally without reimbursement. I know a lot of doctors that will snap a picture of an EKG or snap a picture of a rash and send it over to the dermatologist or the cardiologist, and they'll respond informally over text, secure text, and they'll basically diagnose it there. So I see that a lot, but a formal process where you got to have equipment, a secondary room that you can't use for routine visits, it gets very disruptive.
Okay. And I will say healthcare has, to me, been a consumer product for a very long time in general, but and then for DMHC, one of the things I hear about from my members is the distance rule, that they may have a plan, whomever they have their plan with, up in Susanville, and can only go see or go to access this one hospital, but it's inconvenient, and it would be easier for them to go elsewhere if they were able to based on their zip code. And I get a lot of questions about that, and I don't understand that rule. If you could help me through that.
Sure, thank you. So what we're measuring is basically the plan's network. And so what hospitals and providers the plan decides to contract with, that's how we determine whether they're meeting the standards of access as I laid out. And keep in mind that the hospital is one of the areas or the providers that we can approve an alternate access standard for. But again, we're looking at the plan's network. So if the plan doesn't contract with that hospital that member wants to go to, there's really nothing that we can do about that. So we just want to make sure that if the contracted hospital is further away, that there's some reasonable plan for the health plan to make sure that member can get there, whether it's through transportation services or other types of services that may be outside of the normal scope of the healthcare.
So it's not really, I kept hearing it was zip code, had to do with their zip code. It's more the plan then. And
well, we look at the plan's network by zip code. So we take a point in the zip code and measure the distance. I mean, we have like a whole computer program that does that. But yeah, but that's how we do the networks review.
So if we're enabling better access, would it make sense for us to look at changing those regs in some way so that access to care can be a little more free for those members that are in these rural areas that feel like sometimes they even have to go to Oregon to access care.
I understand. Yeah, I know it's extremely challenging, and that's why we do have the alternate access process that the plans can request us to approve an alternate access standard in a particular area. And one of those could be going to Medford or Reno if that's where the care is contracted with that plan.
Yeah,
So
but the member doesn't know to do that,
Yeah.
right? So member doesn't know that you're involved. The member only knows they can only go to this place.
Right.
And it's a one-off, so each member doesn't know they should go to that one place, that one hospital that they're contracted with, and tell the hospital, hey, can you get this changed somehow so I can access it elsewhere? You see what I'm saying? So it's a situation where the members don't know this.
Right.
They don't know.
I mean, the members should be contacting their health plan if they're having an access problem and see if the health plan can help them work something out. But the chances of them being approved to go to a non-contracted hospital when there's one within a geographic range that we've approved is probably pretty slim, frankly.
Exactly.
But I do understand it's a huge challenge. I don't think it's so much the limitations on the time and distance, because again, we do have that alternate access process. It's more a function of which providers the plan is actually contracted with in those areas.
Okay, so I'm just thinking that might be a policy issue. And then I had a question on, as we do the telehealth, are we like making it harder for us to recruit and retain doctors in rural areas? I understand that DMHC is doing this really good program, it sounds like. So when mergers are coming along, they're requiring that so much money gets put in to this program that I wasn't quite clear on, but that would help train and retain doctors in rural areas. Is that my understanding? Is that correct?
Yes, right. The Office of Statewide Health Planning and Development, called OSHPD, has a health professions education foundation. It's a 501c3, so it's a charity that provides loan repayment programs and scholarships to health professionals, and it's not just doctors. It's associated providers and mental health providers and the like, to go and work if they work in a rural area or an underserved area. It could be in a part of Los Angeles that's underserved, frankly, too. That foundation provides these grants and loan repayment programs to those folks. So if there's been some limitations in the funding. In the past, it's been funded a lot by the California Endowment, and actually our governor in his budget is proposing to put some more money into that fund. And in the interim, we were doing the mergers, and so we were able to get the plans to agree to provide some additional money for that program.
So that's a really good idea, except do the mergers end up, I'm very thankful they're putting money into the charity, but do the mergers end up raising costs? Because now you've got, a larger conglomerate pricing us for whatever it is they're pricing us, whether it's CVS and Aetna now controlling pharmacy and healthcare, or whomever. Does that drive our prices up as these mergers continue? And is that a good idea?
What happens as a result of that kind of remains to be seen, although we have, one of the conditions that we have in each of our mergers is that the costs of the merger cannot be used to increase premium rates. That doesn't mean that over time rates aren't going to go up, but that is a concern. It was expressed during the public meetings that we had on these mergers by consumer advocates primarily. That large mergers like this tend not to really benefit consumers from a financial perspective. So we'll have to, that remains to be seen.
Ms. Taylor, that will be discussed in the afternoon.
Oh, well, there you go.
There you go.
There you go. I just thank you very much. I just thought it was relevant because these mergers were mentioned, so I thought that was interesting. Thank you very much.
Ms. Yee?
Thank you, Mr. President. Thank you to the panelists. A few thoughts kind of through my mind as I'm listening to each of you, and it's a nice opportunity to have both regulators and plans at the same table. So I'm going to kind of use this as an opportunity to ask some questions relative to that, not to put anybody in the hot spot. I guess, first off, with respect to telehealth, and I appreciate that throughout the presentation, as the focus has increasingly been on telehealth, that it's also equally focused on workforce. And I think that's something that, as we think about healthcare in so many different dimensions, whether it be demographic changes, whether we think about geographic disparities and other types of disparities, is really still key. From a regulatory standpoint, and I appreciate the work of DMHC, remember when it was established, and it's done some really tremendous work, and it's really, I think, helped inform how we try to get the maximum amount of quality coverage in California. But are there, and Shelley, you don't need to answer this if you feel uncomfortable doing this, but from the plans perspectives and those who utilize or interface with the state, your experience with respect to the state regulatory environment, are there, do you see ways that we can achieve better efficiencies or perhaps even cost savings? Obviously, your interfaces with the state is at a cost to you, but are there better ways to do this with respect to some of the issues that we've talked about today in terms of your interface with the state's regulatory system?
So can you just repeat the last part? Because I thought I was going to go to Shelley's side. It wasn't.
I'm just looking at, from what Mr. Roulard had talked about, we've got DMHC, we've got the State Department of Insurance, we've got Department of Healthcare Services. Yeah. I mean, we've got just kind of this, multi-prong regulatory system at the state level, which I've got to think, from a plans perspective, is at times frustrating, at times costly, at times, not really getting to, I think, the outcomes that we all necessarily want. So I just wanted to kind of get from your perspective, are there ways that the state could be doing our business better?
I think, when we went to the state, when we got the rural contract, received it from the state, we went to them with a proposal to reimburse differently for telehealth. That was, I'd say, almost 4 years ago. Mm-hmm. And at that time, they weren't ready to kind of consider different ways of reimbursement for telehealth. But to May's point, they have come a long way. So the new Medi-Cal policy that's in a draft all-plan letter is actually very promising, and we've been working directly with the state to help shape that. We think it's an option for the rural markets and, frankly, all Medi-Cal members across the state. But I haven't seen regulation at least from our perspective, as a burden. It's really figuring out the best way to reimburse, because it's not really easy. I mean, do you reimburse for each email? Do you reimburse what, there's HIPAA challenges with at home, or if someone uses an app in a coffee shop to talk to a physician. So there's a lot of scenarios with telehealth that you don't necessarily get with a typical physician encounter. So I think being thoughtful and thinking it through with our regulators is the best option, so that we're not going down a path that is HIPAA non-compliant or causes. And I think reimbursing it is tricky. We have to think about how that can best incentivize the right type of access, both on the member side and the provider side. So I haven't seen in this area a challenge with regulation, but I think the new policy with the Medi-Cal, at least the Medi-Cal side, is really promising, and we're hoping that it becomes final pretty soon.
Good. Okay, I appreciate that.
I got to be careful with this question. The legislator passes the laws, and the DMHC is responsible for implementing the laws. She doesn't write them. We do have a lot of agencies that sometimes you believe there's a little overlap. The laws are well intended. They're consumer protections, which we all applaud. But I'd be lying if they do add costs to the system in terms of remaining compliant. They're well intended, but they do get factored into the cost of the insurance that ultimately health plans sell. So I don't think it's a negative thing. It's just something that needs to be said, and I don't think it's any particular agency's issue. It's just that we have there's a strong desire to protect the consumer in this state, which I think is a good thing. So I wouldn't look at it as a negative, just something to be aware of. And so as these laws are being passed, understand maybe some of the implications. And if there's a way to make it get to the same point, but using more efficient methods to do it, we all would applaud that, that conversation.
Okay.
The health plans never want to talk about the regulator when the regulator's in the room. However, let me just say that we are trying to coordinate with DHCS, particularly on the Medi-Cal program, and we work with them regularly to try to sync what our responsibilities are with what they want to achieve. Similarly with Covered California, and we work with the Department of Insurance on when legislation is passed that says we have to have like a standard formulary template or whatever it may be. So we also have a number of work groups and stakeholder engagement meetings with the health plans to get their input into whatever it is that we're trying to achieve, and that's always been really helpful and very informative for us, because we want to make the healthcare system work for everybody. So it's in our interest to engage in those kind of conversations and coordination.
Yeah, okay. No, I appreciate the responses, and that's a little bit more with my controller hat on in terms of how we squeeze costs, so I appreciate it. Second question relates to kind of really where we are with privacy issues on telehealth. So on the one end, we have HIPAA. On the other, probably end of the spectrum, I think, there are policies being established in this fairly new area. And my question really is, from an oversight perspective on the part of the state, what ought we be looking for as kind of the next phase of how we advance privacy protections for the consumer?
That's a really good question, and I am not an expert in this area. But again, it's really understanding what the law requires. Obviously, ensuring patients' privacy is critically important. And so may be able to talk to this more, being the JD on the panel, about just being really careful and cautious and thoughtful about how this all gets implemented.
Yeah, in regards to telehealth, there's nothing really specific where there's a piece of law or regulation says when you use telehealth, you'll do this. A lot of times, if you look at policies that do exist, and a lot of them are really in different states, they'll say you have to follow the same requirements under HIPAA or state laws that you would have if you provide the services in person. And that is part of the problem with telehealth, because it is such an evolving area. You do have these gray areas that Barsam mentioned, where you're like, how does this apply? How do you use this now? Because this is a new way of delivering care, which creates a lot of problems on different levels, like with providers, on like whether they want to use this, how does it go integrated into their workflow. But on the policy end is you have these existing requirements that they have to follow related to privacy or related to how they prescribe. How does telehealth now work into that? And policy has a tendency to develop slowly sometimes. So it is playing catch up to where you go there. When I get that question from providers to say, you're still underneath the same obligations. You still have to follow what it says in HIPAA, so you have to adjust your actions accordingly. But it does get very gray. Like a frequent question I get is, can I use Skype? And can I use this? And it's like, well, let's go through the steps here. What does HIPAA say? Is there a business associate agreement? Are they like, they're going to store information there or access it in some way? So you need to think through that. And I also warn providers, I said, that's HIPAA. HIPAA is your floor. You might be operating in a state where it's a lot more stringent, and there may be also laws that are related to how you provide services over the internet that don't say it's related to healthcare, but you're providing services now over the internet. What are those laws? Be mindful of those that you have to follow. But it is like an evolving new era here, and hopefully something will come over the next couple of years that'll be a little bit more solid, and people will have like an actual policy that they can point to and follow. But until then, providers, health plans, everybody really is just trying to adjust to like the framework we have now.
Okay, that's great. If I could have one ask of that as you're developing those, and that is to really at the same time think about how you're going to translate that to the consumer. It's their data, it's their health, and I think in terms of how that data is transmitted, who it's shared with, all of that for the consumer to better understand that in this new way that we're providing health care and services would be great. And then lastly, we had the devastation of the Camp Fire up north, and I know that it really put a lot of systems to test. And I wanted to just ask you if there were lessons learned with respect to the adequacy of our network in the north part of the state that can help guide us going forward. And I know, Kathy, that's a question for you or others who have experience up there.
Well, I appreciate that. That's a very thoughtful question. We were absolutely shocked. I went to middle school in Chico. I know Paradise well. I know Reading well. We do have that wonderful Inlow Community Hospital. But their sister city is Paradise with the Adventist Hospital there present. I think even though we talked about the rural north, the north and the east, we do have to preserve what's happening in the north part of the valley in terms of Chico and Reading, up into the up into the kind of the getting into the mountains. We do have hospitals. I did want to say one point about the district hospitals. Reading is owned by the Mercy Health System. Up in Del Norte, that district hospital is held by this is owned by the Sutter System. Aldo touched upon it briefly that we do deal with some sort of monopoly behavior in some of these areas. So our relationship to our hospitals in those areas is delicate in terms of the memberships that they serve, but also wanting to make sure that they're through our health plans that they're getting adequate reimbursement. So those are important to us. I felt that Inlow stepped up to take in our members, our patients, the doctors, the nurses, and I think that is a direction we have to pay attention to going forward, is that if we are going to be having these catastrophic events, how do we preserve the relationships with the scarce resources that are available in those areas?
Okay, Mr. Rubalcava.
Thank you, Mr. President Jones. Very, very interesting presentations. I understand because of the resource and characteristics of these rural areas that oftentimes especially in the remote areas, that the PPO seems to be the most available arrangement. However, we are interested in health outcomes and efficiencies, and I noticed in Dr. I want to pronounce that correctly here, Kasaravi presentation, he mentioned, I was happy to hear that there's a readmission reduction initiative, but another statement you made was that the markets are not welcoming of managed care. I was hoping you could expand on that. Is it because from the patient side? Is it the independent physicians? Is it the medical groups? When you said market, who's the one that's not welcoming, and why do you think are the barriers there, or what are the considerations? Thank you.
Another hot button topic, but I'll try to. This isn't being recorded, right? No, thank you for that. I mean, I think that when we went to the rural markets, that it was just managed care in general was new. So the idea of utilization management for a lot of the hospitals to get authorizations for diagnoses, and we had a lot of education of sending medical records, things that we tend to with other hospitals in our other 20 counties had been routine for for a decade or so. So I think given that it was new to the providers, mainly the hospital providers, I would say, were challenging. The other piece was having, after a couple years, we introduced the medical group model in the rural markets, which, actually some of the clinics wanted and welcomed that coordination of care, which is the ultimate goal. But, we think that it added an additional layer to our connection with the clinics and the providers. So it added some confusion of, whose network, is it the Anthem network versus the medical groups network? And then the providers had to contract with that medical group in addition to Anthem. So I think that there was just a lot to absorb with some of these counties when it came to managed care, which had been in place in other markets over, I'd say, a couple decades. We're ironing out some of those, and I think with the feedback that we've received, working through some of those challenges. But it was mainly, I'd say, the hospital providers, but also some of the specialists as well. And
if I could do a follow-up question. So did you, through this coordination of care efforts, did you see any improved health
Yeah.
outcomes or anything?
Yeah, so one thing we did was we now are embedding clinicians, nurses in the hospitals like Oroville and Enloe and other hospitals, which has helped us not only get access to real-time clinical information, we also have access now to electronic medical records at the major hospitals in the rural counties. That has helped us get access to data and information more real time so we can coordinate the utilization management process, but also as the members are leaving the hospital, we do much more on-site discharge planning. So the member sees an Anthem nurse before they leave the hospital if they're a high-risk member, and then that same nurse follows them to their PCP appointment, and, goes with them to their PCP appointment, looks at their medications. And so we've seen that really work well. That requires a partnership with the hospital, with the federally qualified health center. For this example, it's AMPLA. So there are stakeholders that we've been working with to reduce readmission, and it's been very successful. This program's been one of the few readmission reduction programs that has shown a pretty strong result as far as reduction. But it is resource intensive. It requires recruiting nurses as a payer, recruiting nurses in those counties, which is difficult enough because there's the other options of working for the hospital, working for the clinic, and then embedding them in the facility, which is also a challenge. Sometimes the hospitals don't necessarily want, as Aldo's mentioned, payers in the hospital system. So we have to have some level of trust where we say it's a win-win for everyone to have that better coordination.
Thank you.
Mr. Miller?
Yeah, thank you, panelists. This has been really fascinating to me. A couple observations and then a specific question or two. The last time I was gainfully employed full-time in healthcare was long, long ago. I was around for the incredible battles about putting someone on a gurney, sticking them in an ambulance, and going like hell to get to the hospital versus actually working with a physician, telehealth, to be able to actually start an IV, for God's sake. Oh my God, someone who's not a licensed practitioner doing something like that was a big deal in the 70s. TV show really helped change that around the country a little bit. But and the early days of arthroscopy and the very first liver transplant, one of my big bosses made headlines for that. But what excites me about this is all those struggles about, oh, this is a new paradigm, oh, it's so hard to get the cultural acceptance, the political acceptance, the regulatory infrastructure is going to change. And yeah, it was slow. It lagged where we needed to go, but it got there. And I look at all this and say, it's the same thing. There's so much tremendous potential for effectiveness, efficiency, for improving healthcare delivery and outcomes. But we got to work through all that stuff and be patient, because it's gonna take time, but it has such tremendous potential. And I'm so happy that both the industry and the regulators and the providers that we work with, and everyone is being tenacious about this stuff and about getting it right and working our way through all those many moving pieces. But one of the pieces that seemed apparent even way back then to me was things like early efforts to move to these CBOCs, these community-based outpatient clinic type models, would overcome those hurdles, eventually telemedicine. But one of the things we saw, and I still kind of see and would like your view on, is when it comes to physicians, when it comes to physician recruitment, retention, when it comes to capacity, there seemed to be a huge bottleneck at the kind of traditional allopathic medical college system, university in the US, that even back then we were seeing as like, we got to do something about this. We've got to figure out a way to increase that pipeline, produce more qualified physicians, and a lot more of them. But there were all these constraints, some healthcare related concerns, others more big picture political. And even then, it was, well, how do you deal with that? And even back in the 70s and 80s, well, we'll try to access talent from outside of the U.S. We'll try to, and even today, while we utilize more talent from outside the U.S., we've finally started to appreciate osteopathic medical education, but we still, seems to me, have this real constraint of the pipeline, of the supply, that we could be educating and preparing a lot more physicians and other clinicians, but especially physicians who could do good in our communities. But so do you see anything from a much more current perspective happening with that regard, in terms of, how do we get more doctors, their diploma and into residencies and out there in our communities?
I'll take a stab. Thank you for the question. And this is actually a subject that makes its way into my world because the parent company of my health plan is a hospital system. And we just announced a new medical school in the Fresno area, so there'll be a medical school, which is great. But it's interesting when you look at this, it's really not the medical school, it's the number of residence slots you have available. The Medicare will cap your school at a certain amount of residence slots that they will fund. And if you want to provide residency above and beyond that, then you, as the hospital system, must fund the entire amount. So, and that cap rarely moves. So there's your bottleneck. So we have plenty of medical students that would love to be trained locally, and as Barsom said, the statistics are true. If they train in your area, they're more likely to stay there. So it's really the residency spots. So the parent company, we are probably close to 100 slots above the cap that we fund entirely from the hospital operations. So part of it could be legislation, it could be new dialogue with the government to fund these new slots above the cap or adjust the caps to do so. And that's as much as I pretty much know about the program. That's where I see the bottlenecks, where we see them, when I see them tangible and real. And it's probably the tyranny of the anecdote, so I apologize for that. But it is a real problem. But we do have a new medical school coming online. We do have a residency with UCSF in the Fresno area. We train family practice physicians, internal medicine, you name it. And it's been helpful because they typically stay in the area for a period of time. But I do think it's the residency spots that create that bottleneck that you're describing.
Yeah, thank you for that question. I think, being a family physician, I think the family medicine residency model is a pretty good one. It's very community-based. It's affiliated with, community hospitals. It's unique, but I think when you look at, all of the points Aldo mentioned are critical, but the medical school education has historically been academic medical centers that have brought kind of medical education along. I think, I don't have the answer to how we train more doctors. I think it's complicated. There's a lot of physicians not going into primary care because of the amount of loans they have to begin with. So, I have friends that went into anesthesia and dermatology and orthopedics. I was probably the only one of my friends that went into family medicine, and even myself, I'm not necessarily practicing. So it's a tough model to go into primary care particularly in rural markets, and be able to pay back your loans unless you're lucky enough to get some help. But for the majority of folks, they tend to go to other specialties that have better work-life balance and potentially a lot more reimbursement. So. But the medical school education is a challenge. I've always felt that, you cannot necessarily sustain an amount of physicians by having them be trained at the UC system only, or at now Kaiser has a medical school that they're opening up, and it's like a big deal that Kaiser is opening it up. But why isn't like Chico State opening up a medical school, or other universities or nursing schools? So, I don't know how the funding flows for medical education, to be honest. But I think it does start with medical education and other allied healthcare providers' education, and where that adds to the capacity. And then the residency slots does become an issue, and I think that's something we'd have to tackle. But I think the days of having everything be at the academic centers and having all the training be there, which is, I went to UCLA Medical School myself, and I just saw that the residents there was just so much education happening there, but then the second you go outside of LA, it's almost like a desert, an education desert. So we need to get that education further away from those centers, because that's not a realistic healthcare in most of California, because it's all transplants and it's all very tertiary, quaternary care, and get more community hospital education and rural hospital education.
Okay, all right. Okay, I'm going to call on Mrs. Brown, and this will be the last request to speak for this session because we have to move on. Mrs. Brown.
My question is for Shelley. For 2019, thousands of CalPERS members had to change their health plans, and a number of our retiree associations are hearing from members that have these new plans that they can't find a primary care physician in network accepting new patients. As an example, the California State Retirees did a search for Santa Rosa and found that 43 of 50 primary care physicians were not accepting new patients. And I understand that DMHC enforces a law that requires carriers to post on the website a list of network providers that are accepting new patients. I think it has to be updated, I don't know, every couple of weeks. And I'm wondering, is that law working? Are insurers complying? Have you done any enforcement? And also, when you determine adequacy, do you consider the number of physicians accepting new patients? Because it really is critical for us.
I really appreciate that question, because this whole issue of provider directories and what is accurate in those lists that everybody relies on to decide to understand who's available is really critical. And that's part of the reason why in another merger, in the Blue Shield Care First merger, we required Blue Shield to contribute $50 million to a solution around the accuracy of provider directories, which was a huge problem. And I'm happy to say that that solution now exists in the form of, it's called Symphony Provider Directory Utility, and it's being run by the Integrated Healthcare Association. They got the grant from Blue Shield to create this. So in terms of, this is just in its initial phase. They just did their soft launch at the end of last year, and they're now recruiting health plans and provider organizations and individual doctors and other providers to sign up, so that there's a centralized location where all the health plans, well, actually all of the providers can update their data one time about, what their office hours are, whether they're accepting new patients, what languages they speak, where they're located, their credentials, all of that. And then the health plans can get that data from this single source and populate their provider directory. So it's not fully operational yet, but it's in the process of development, and I'm hopeful that in the next year or two, you'll have a lot more accuracy around allowing consumers to understand who is accepting new patients and where these providers are located and who they can serve. With respect to your other question about in considering network adequacy, do we look at whether people are accepting new patients or not? That is not a part of our review. We're looking at the whole network as a whole, and providers constantly change whether they're accepting new patients or not, and some of them may limit the number of certain types of patients they take, like Medicaid patients. Others may have a full practice, but then one of their they may get a new provider in that allows the patient population to be spread over, more physicians, and that may open up a practice. So that's an ever-evolving change, and we are hoping that with the Symphony, that because the plans and the providers will be updating that data on a regular basis, that at least there will be more likelihood of having accurate information at that time. But it is a huge problem, and I'm happy to see that the industry has pulled together to create this solution that we hope will work.
Yeah, I just wanted to echo as a plan that Symphony is a game changer. We're really excited about having this be launched. So I think you'll see a lot of improvement, at least on the provider data side, which the plans were struggling with as well, because providers had to update multiple health plan data sites, and I think this one source of truth is going to really make a big difference.
Great. Thank you.
Okay, thank you all for the discussion, and that was a very helpful overview of the challenges and some intriguing potential solutions, whether through telemedicine or coordinated care. And so thank you to all of the panelists for being here today and sharing your insights and thoughts with us. So why don't you join me in applauding our panelists?
Thank you. Are you taking it?
And housekeeping, Karen, where are we with time?
Thank you, Henry. We're going to take a quick 15-minute break, maybe 14-minute break. Let's reconvene back here at 11:25 for our next session. Thank you.